بسم الله الرحمن الرحيم. أهلا بحضراتكم in Novo Symposium. One of the important sessions in our meeting. It is hybrid. We have also online registration of a huge number. So we're going to start. My pleasure to co-chair Professor Magdi Helmi, head of Endocrine and Diabetes Department in Alexandria University. It's my pleasure to be with you, Professor Magdi.
Thank you very much, Professor Inass, and thank you again for inviting me. It's always my pleasure to be a part of the activities of the ASD conference. Thank you very much for that. My pleasure to introduce Professor Inass Shaltout, answering a very important question: why should obesity be treated as a chronic disease? Please, Professor Inass.
Bismillah ar-Rahman ar-Rahim. Very important topic. Why should obesity be treated as a chronic, serious disease? This is the global prevalence of diabetes, overweight and obesity. During 2020, we had 2.2 billion persons suffering from either overweight or obesity. By 2030, we're going to have 2.9 billion persons living with overweight or obesity. By 2035, we're going to have 770 million young people below the age of 18 suffering from either obesity or overweight. This is a global problem. We come now to the definition of obesity, and previously we usually define obesity by BMI, body mass index. It's time now to shift from just measurement of BMI to a weight-centric definition, and we focus on the overall health, not just weight and height. Obesity is defined as a prevalent, complex, progressive, and relapsing chronic disease. Then obesity is a relapsing and chronic disease characterized by abnormal or excessive fat deposition or adiposity. This fat deposition impairs health. BMI and waist circumference can just be used for screening. We all screen our patients by BMI, weight and height, and measure according to either between 20 and 25 or above 25 or above 30, and the grading of or the stages of obesity. Diagnosis and staging of obesity should take into account the presence of functional, medical, and psychological impairment. Functional impairment, like, for example, suffering from weight-bearing joint problems, from back problems, from urinary incontinence, or from obstructive sleep apnea. Medical complications, we're going to find huge number of medical comorbidities and complications of obesity we're going to discuss soon, and psychological impairment related to the presence of abnormal or excess fat. This is important, or more important than just using weight and height. There is a new framework for the diagnosis, staging, and management of obesity in adults, according to EASO, the European Association for the Study of Obesity. And those different associations and organizations, the World Obesity Organization, WHO, EASO, American Medical Agency, the Royal College of Physicians, the Obesity Society, European Commission, the Obesity Canada, all these associations consider obesity as a chronic disease, serious disease, relapsing disease, and this needs urgent management and continuous management. It's not just a shape. The shape is a personal factor, if the patient likes his shape or not. But from our medical view, this is a chronic and serious disease. These are the different groups of complications due to obesity. We have metabolic complications, mechanical complications, and mental complications. From the metabolic complications, we find muscle, fatty liver disease, gallstones, infertility, cancers, cardiovascular disease in the form of stroke, dyslipidemia, hypertension, coronary artery disease, pulmonary embolism, and HEP-REF, or heart failure, preserved ejection fraction, type 2 prediabetes, thrombosis, and gout. From the mechanical complications, we find GERD, physical functioning and mobility, asthma, urinary incontinence, knee abnormalities, the weight-bearing joints, sleep apnea, and chronic back pain. From the mental complications, we have sense of depression and anxiety, absence of sense of well-being, financial problems due to obesity, unemployment. We have many serious mental and psychological complications due to obesity. How to measure abdominal obesity and why abdominal obesity is important? Because abdominal obesity is an independent risk factor for cardiovascular disease, for premature mortality, and for diabetes. Then we should stress on the presence or absence of abdominal obesity according to the measurement of waist circumference and the waist to hip ratio and the waist to height ratio. Waist circumference is widely used, and waist to hip ratio correlate with the metabolic risk. We can use some instruments to detect the visceral fat, the intra-abdominal fat, by using the DEXA. The DEXA is not that accurate. Maybe more accurate is the CT and the MRI to detect the intra-abdominal fat, but the DEXA is considered less exposure to radiology and less time consuming, so we can screen by DEXA, but for accurate screening, we need either CT or MRI. These are the cardiometabolic risk factors need to be assessed in any patient with overweight or obesity and to be effectively managed. Systolic blood pressure, we screen for blood pressure where there is high blood pressure, we need to manage the presence of abnormal liver functions, the presence of diabetes or pre-diabetes by fasting plasma glucose or hemoglobin A1C, and the lipid profile. These cardiometabolic risk factors need to be addressed and need to be managed. Going beyond the BMI-centric view on obesity, we have other staging systems like the IASO staging system, like the King's obesity staging criteria, like the obesity surgery mortality risk score, and the Rethink obesity risk assessment. And one important staging system is the Edmonton obesity system, which is Canadian. And let's start with the Edmonton obesity staging system. We have different stages. Let's start with stage 0. Stage 0, there is no medical complication of obesity and no mental complication of obesity and no functional complication of obesity. Then we are not here concentrating on BMI. We are checking the whole medical condition of the patient. For stage 1, the medical complication can be in the preclinical condition, like pre-diabetes or pre-hypertension. For the mental, patient can suffer from mild mental or psychological comorbidity, like mild depression, for example. For functional complication, we can find, for example, problems in the weight-bearing joint, or problems in the back, or stress incontinence, or a mild case of obstructive sleep apnea. For stage 2, there is actual comorbidity in the form of diabetes, hypertension, dyslipidemia, fatty liver disease. Many complications can happen, and the mental condition, moderate mental suffering or psychological suffering, and moderate functional comorbidity or complication of obesity. For stage 3, we reach end organ damage due to the previously mentioned diseases, diabetes, hypertension, fatty liver disease, and the mental complication is severe and the functional complication is severe. For example, obstructive sleep apnea can be dangerous in this condition. The stage 4, we reach the end stage of all complications of obesity, the medical complications, and also mental and functional complications reach an end stage. The weight-centric approach to health, we have either obesity or adiposity, leading to those complications mentioned before: obstructive sleep apnea, NASH, osteoarthritis, hyperlipidemia, hypertension, type 2 diabetes, and coronary heart disease. And all these will lead to macrovascular complications, while type 2 diabetes and hyperglycemia itself can lead both to microvascular complications. This is the glucocentric approach. We only concentrate on glucocentric, or to just adjust the blood glucose level. We need to move to the left side of our slide here to weight-centric approach. If we started with weight reduction, we're going to reduce the burden of all complications of obesity. Few people living with obesity achieve and sustain clinically relevant weight loss. This is the ACTION trial, which is awareness, care, and treatment in obesity management. And of the total pool of people living with obesity, only 10% maintained more than 10% weight loss for a year or more. This is the result of the ACTION program or ACTION trial. And only 10% maintained more than 10% loss for a year or more in different countries, in Canada and in US. And only globally, 5% maintained more than 10% weight loss for more than a year. Then only with lifestyle modification, only 5% can maintain more than 10% weight loss. And this is a long-term approach to obesity management. It is required to maintain weight loss, and in this study for the first 6 weeks, those patients took only lifestyle modification with reduction of calorie intake between 1,200 and 1,800 calorie intake per day. By the end of this 6 week, by the end of this 6 week, there was 2 groups. One group was control group only on this caloric reduction, and the other group took one of the anti-obesity medication. We can find here that the control group on lifestyle modification started to regain the weight again, while those on medication could maintain the weight loss for a longer duration, more than 24 months in this study. Another study for treatment to maintain weight loss, the scale maintenance trial. The scale maintenance trial, at the baseline, the mean weight or the baseline weight was about 100 kilogram. there was a run-in period of 12 weeks. During this period, lifestyle modification, exercise, and caloric reduction. The caloric reduction was between 1,200 calories to 1,800 calories, and all these patients could achieve 6% weight reduction by the end of the 12 weeks. Then, after this, there was two groups. One group was on lifestyle modification only, caloric deficit of 500 kilocalories per day, and lifestyle modification exercise. The other group received liraglutide 3 milligram, and by the end of this study, we can find here that the group on lifestyle modification could achieve a baseline or just reduction of 0.2% of the weight. The other group with liraglutide 3 milligram could achieve 6% weight reduction in addition to the previously 6% weight loss. Then we have 6% from the beginning in the run-in period, and another 6% weight reduction, or 6.2%, due to the use of liraglutide. Then, by the end of this study, liraglutide could achieve 12.2% weight reduction. 81% of individuals in the scale maintenance study could maintain the weight loss. Compared, this group is the liraglutide group, in comparison to 48% in the placebo group. Then the liraglutide group could succeed in maintaining weight reduction in 81% of the patient, compared to 48% in the placebo group. More than 5% of patients, more than 5% of weight loss could be maintained in 50% of the cases on liraglutide, compared with 21%. يعني 50% من المجموعة اللي كانت بتاخد liraglutide قدروا to maintain أكتر من 5% weight loss. والناس اللي قدرت تمنتين أكتر من 10% weight loss كانت 26% في الليراجلوتايد versus 6% في اللايف ستايل موديفيكيشن. This is the mean change in body weight over time by intensive behavioral therapy. Intensive behavioral therapy in the upper part of the figure اللي هو بالرمادي ده. intensive behavioral therapy دي في study تانية نزل الوزن 6%. لما اجي اقارنه بالمجموعة التانية اللي هي اخذت intensive behavioral therapy with liraglutide قدر ينزل الوزن، لا معلش، قدر ينزل الوزن كمان وصل إلى 11.5%. يبقى استخدام الليراجلوتايد مع الانتنسيف بيهيفيرال ثيرابي نزل الوزن فوق ال 6%، نزله كمان 5.5%. فالعينين في آخر الاستادي وصلوا إلى 11.5%. Weight loss alters the body homeostatic system to limit weight loss and favor weight regain. طبعا كلنا عارفين ان حتى العيان اللي بيعمل دايت بيجي لحضرتك بعد فترة هو بيعمل دايت ستريكت دايت وبعدين يجي بعد فترة يوقف الدايت وزنه بيزيد. طب ايه الميكانيزم؟ الميكانيزم ان الجسم نفسه بيحاول اولا to accommodate to the new caloric intake. يعني جسم كان متعود بياكل 2500 كالوري في اليوم، لقى نفسه بياكل 1200 كالوري في اليوم. في الاول بيبتدي يخس، لكن بعد شويه بيقلل البيزل ميتابوليك ريت وبيقلل الانرجي اكسبندتشر بتاعته وبيزود الهنجر وبيقلل السنس اوف appetite suppression اللي عنده او احساس بالشبع، فيبتدي العيان تاني ان هو يسمن مره تاني. ده اللي بيحصل هنا، ان بيبتدي يزيد الهنجر عن طريق الهنجر هرمون اللي هو اهم واحد فيهم اللي هو الجريلين. بيحصل انرجي جاب، بيقلل الانرجي جاب بتقليل الانرجي اكسبندتشر، يقلل الحرق بتاعه. واحنا كلنا بنعرف القصه دي ان العيان بيبتدي يقلل الحرق بتاعه. حتى في بعض الناس تقول لك ايه، طب ادي وجبه فري، طب ادي يوم فري عشان الخبط الجسم، العيان يفتكر ان انا هديله 3000 كالوري في المره، مره ثانيه كمان يوم يبتدي ايه الخبطه عشان يبتدي تاني، ابتدي من اول وجديد تاني ان انا اقلل الكالوريك انتيك. فده اللي بيحصل، ان احنا هو الجسم بيعمل كومبنساتوري ميكانيزم ان هو يزود الهنجر. لما يبتدي الواحد يخس يزود الهنجر عن طريق مينلي الجريلين، ويبتدي كمان الحاجات اللي هي بتعمل شبع زي الجي ال بي 1 بيقللها، زي الانسولين بيقلله، زي الليبتين بيقلله. حاجات كلها بتقلل الساتايتي وبتزود الهنجر وبتقلل السنس اوف ساتايتي. تقليل الانرجي اكسبندتشر بيبقى عن طريق تقليل البيزل ميتابوليك ريت وتقليل الانرجي اكسبندتشر. بعد البارياتريك سيرجري بيبتدي يحصل حاجه في اول سنه اللي هو الجي ال بي 1 بيبتدي يزيد، وده بيبقى له افكت على نقص الوزن في بدايه اول سنه. ولكن باي تايم زي ما احنا شايفين في البارياتريك سيرجري بيبتدي ينزل تاني، فالإفكت بتاع الجي ال بي بيبقى lost by time. وعشان كده بنلاقي ان في عيانين كتير بعد البارياتريك سيرجري بيبتدي وزنهم يرجع ويزيد مرة تانية. This is the role of the brain in regulating eating behavior. الحقيقة السلايد دي is very interesting. عندنا 3 أنواع من الإيتينج، 3 أسباب إحنا بناكل ليه. أول سبب الهوميوستاتيك ايتينج. الهوميوستاتيك ايتينج ده إن أنا باكل عشان جعان، اللي بيسموه الأكل بتاع إنسان الكهف، اللي هو لازم ياكل عشان هو عارف ان هو ممكن يقعد 2 3 ما يلاقيش صيد تاني وكده، او الدنيا الجو يقلب فما يلاقيش اكله. فده بيسموه الاكل بتاع انسان الكهف اللي هو الهوميوستاتيك ايتينج. المسؤول عنه ايه؟ هو ده eating for hunger، بناكل عشان جعانين. المسؤول عنه الحاجات اللي بتزود الساتايتي اللي هي الجي ال بي 1، وفي حاجات بانكرياتيك وفي حاجات الاميلين والبوليبيبتايد، يعني مجموعه من الحاجات. وحاجه بتزود الهنجر، وقلنا ان اهم حاجه بتزود الهنجر اللي هو الجريلين. ده الهوميوستاتيك ايتينج اللي هو eating for hunger، جعان فباكل. طيب في نوع تاني من الايتينج اسمه هيدونيك ايتينج، اللي احنا بنسميه eating for pleasure، اللي هو واحد مش جعان خالص لكن وهو قاعد كده، لا انا عايز ايس كريم، ماما ابعت اجيب ايس كريم او ابعت في شوكولاته في الثلاجه، فيبتدي يفكر في حاجات وهو شبعان تماما. غالبا الحاجات دي بتبقى يا اما شوجري يا اما فاتي، يعني بيدور دايما على حاجه شوجري او على حاجه فاتي، بتعمل سنس اوف بليجر. وده بنسميه الايتنج بتاع الطفل الصغير اللي هو بيدور على الحاجه الحلوه. مين المسؤول عن المجموعه دي؟ اللي مسؤول عنها الدوبامين كنترولز وونتنج، انا عايز ايس كريم دلوقتي، عايز شوكولاته دلوقتي، والاوبيويد والكانابينويد ريسبتورز. فده اللي بنسميه الهيدونيك ايتنج او ايتنج فور بليجر. في بعد كده الاكسيكيوتيف فانكشن، قرار deciding to eat. انا هقرر ان انا هبعت اجيب اكل دلوقتي، انا ولا جعان ولا ساعات ما يبقاش ميعاد اكل، بس في decision of eating، او معزوم دلوقتي وعارف ان انا هاكل بعد ساعه. ده قرار، ان في قرار اكل، ممكن ما يبقالوش علاقه خالص جعانين او مش جعانين، ولكن في قرار للاكل، في فاميلي جاذرينج، في قرار ان احنا هناكل بعد ساعه، مش لازم نكون جعانين. deciding to eating زي ما بنقول، وده behavioral intervention empower sustained behavior in controlling eating. يعني لما نيجي نعالج الموضوع ده لازم اعمل العيان بتاعي behavioral therapy. طيب مين اللي بيشتغل على الحاجات دي؟ اولا لايف ستايل، ان انا مواعيد الاكل مثلا تبقى متظبطه قبل كده، ما اجيش في اي وقت تعالى الوقت نخرج ناكل يبقى اخرج اكل وهكذا، لا يبقى عندي لايف ستايل موديفيكيشن مع الدكتور بتاعي او حتى مع نفسي ان انا اقرر ان انا ليا مواعيد منظمه في الاكل، ما اكلش 5 مرات في اليوم، لا انا اكل في مواعيد محدده. الحاجه الثانيه بالنسبه للايتنج فور بليجر، ده محتاج سايكولوجيكال مانجمنت، سواء كان مع الدكتور بتاعي او مع حد سايكولوجيست بيتكلم معايا، اغير من العادات بتاعتي. انا عارف مثلا بدل ما احط حلويات في الثلاجه، لا الحلويات تبقى بره البيت خالص. يعني ابتدي اعمل حاجات ان انا ابعد عن اي موتيف. والله انا عارف ان انا لما بروح المول ده ان في واحد بتاع ايس كريم هنا، لا ما اروحش، او اروح اشتري من حته تانية، وهكذا. ان انا اغير قراراتي. اروح السوبر ماركت وانا شبعان، دايما يقولوا كده روح السوبر ماركت وانت شبعان، او ما تروحش السوبر ماركت خالص، ابعت تشتري الحاجات المفيده ليك بس اللي انت عايزها. لان انت لو قاعد في البيت بتكتب لستة مش هتكتب حاجات غريبه، لكن لو رحت السوبر ماركت هتلاقي نفسك في حاجات شفتها قصادك وهكذا. او لو دخلت على الابلكيشن، برضو دلوقتي مشكله في الابلكيشن ان انت لما بتعمل ابلكيشن من حد محل اكل او سوبر ماركت هتلاقي حاجات في النص كده ما كنتش ناوي تشتريها، هتلاقي نفسك بتشتريها. طيب eating for hunger العلاج بتاعه is medication and surgery, anti-obesity medication or metabolic surgery. احنا اتكلمنا عن الموضوع ده في اول يوم، ارجو ان تكون حضراتكم حضرتوا المحاضره. Anti-obesity medications versus bariatric surgery. Let me summarize my presentation. The global prevalence of people living with obesity is high and it is increasing. Obesity is a complex chronic disease, relapsing disease, caused by interplay of biological, environmental, and psychological factors. Various studies showed that sustained weight loss is challenging for people living with obesity. مش سهل قوي ان انا to sustain the weight loss. And liraglutide 3 ملغ استاذ دكتور مجدي بيه هيكلمنا عليه provide a significant weight loss maintained over time. Thank you very much.
Thank you very much أستاذتنا العزيزة، كالعادة السهل الممتنع. Yes, obesity is a chronic relapsing disease. وإذا كان الweight loss is a challenge, to maintain this weight loss is more challenging. Thank you very much Professor إيناس. لو في أسئلة الأستاذة إيناس.